Good evening and welcome to this webinar being put on by the European Law Institute, or ELI. About a year ago, or just under, as the current pandemic was getting underway, the ELI decided it would be in the interests of everyone if it set out some basic principles which would guide all the institutions of government and courts and legislatures across Europe in dealing with the unprecedented state of affairs brought about by the pandemic. It was necessary, we thought, to provide principles that would ensure that the extraordinary measures that have had to be taken, and which it was envisaged would be taken at that time, were principles that were grounded in the rule of law and in democracy and in the respect for human rights and basic and fundamental values. And I think it's fair to say that these principles, although drafted at some considerable speed, have received very widespread welcome and acceptance across the whole of Europe, the European Union, and the countries served by the Council of Europe. We now hope and are, I think, emerging from this crisis. And it was therefore necessary, we thought, to provide two further principles in addition to what we had drafted at the time. And those principles relate to two areas. That is, what is to be done as you emerge in relation to areas where there's a low epidemiological threat. And secondly, what you do about the distribution of vaccines. And we've chosen two fundamental principles of the rule of law, one proportionality, and the other is equality, which must apply as further fundamental principles to be applied during this period. These matters, I don't think, were envisaged because everything was so new a year ago, but now it seems important that we pay close attention to them. And tonight, to discuss these principles, we have a small panel, two from the ELI itself and two great experts who've come to express their views. But I think it would be best if we started with explaining the principles. And we're going to go to principle 16 first, which Professor Christiane Wendehorst is going to explain to you. She knows absolutely no introduction from me. She's well known across Europe and has played an outstanding role in the establishment of the European Law Institute, the work it has done, and the way it has moved its direction to make sure that it remains at the forefront of the development of the law in Europe. Professor Wendehorst.
Well, thank you ever so much, John. I will go quickly through the draft Principle 16, and let me stress that this is a draft because both principles which we are presenting tonight are currently being scrutinized by the ELI membership, and we are already getting very valuable feedback. So those principles will certainly be revised in due course before they are going to be submitted to the ELI Council. Now, draft Principle 16 is about the proportionality of measures in cases where certain individuals pose a much lower epidemiological threat than the average population. We are currently witnessing a very ambivalent phase of the pandemic. On the one hand, large parts of Europe are experiencing a third resurgence and are extending lockdowns and similar measures, or even imposing new ones. But on the other hand, an increasing part of the overall population in Europe will soon have been vaccinated against COVID during the spring months, or will have recovered from the disease. And in addition, improved testing capacities mean that it has become much easier to tell with an acceptable degree of certainty whether or not a person can currently spread the virus. So at some point, no doubt, this will lead to a situation where restrictive measures can gradually be lifted again for the whole population. At least this is what we all hope. However, and this is what Principle 16 is about, the question arises whether states should wait until this point, or whether the time has come to lift certain restrictions on a more individual basis for those persons that pose a low epidemiological threat to their environment, in particular because they have been vaccinated, tested negative, or have recovered. And this is also suggested, not mandated, but suggested by the recent initiative of the European Commission to launch the digital green passport, which we're certainly going to talk about later. Now, the answer to this question depends to a very large degree on scientific evidence. In particular, scientific evidence about the extent to which vaccination or natural immunization protects not only the individuals themselves against severe symptoms, but also against transmitting the virus, and scientific evidence as to the accuracy of testing facilities. Much is still in a flux here, and we largely have to depend on data from very few scientific publications. It is definitely not for the European Law Institute, let me stress this, to take any sort of position in this regard. So I have to stress that anything you find in the draft Principle 16 can be valid only under the condition that there is appropriate scientific evidence for a negligible epidemiological threat. But even if we assume that it is in fact proven that a given individual poses no or very low epidemiological threat to others, lifting restrictions, not for everybody, but only for particular individuals, is still a very controversial thing from an ethical point of view. Many people consider this to be an additional privilege for some happy few who have already received vaccination, and maybe something that goes against the spirit of solidarity among the population. Some people have gone so far as to disqualify this as unlawful discrimination of non-vaccinated individuals who would be required to get regular testing in order to enjoy similar freedoms, if maybe not an infringement of human dignity, which we have read in several statements made. We believe in draft Principle 16 that this is not the right approach to take. We have so far taken a different position, which is a position that has its starting point in citizens' fundamental rights, understood primarily as rights of the individual, and in the proportionality principle. In our view, any kind of restriction of citizens' freedom to move, meet, work, enjoy cultural events, and so on, is in need of justification and must be strictly proportionate. If there is, in the light of scientific evidence, reason to believe that a given individual does not pose a significant epidemiological threat, we believe that from a legal point of view, the state may no longer have a justification to lock that individual in or to impose other far-reaching restrictions on that individual. It is not a privilege for an individual to have that freedom, but just normality, while it is always the restriction that is in need of justification from a legal point of view. Whether or not lifting restrictions is in line with the idea of solidarity may be something each individual should decide, but it is not for the state to impose a particular notion of that on each individual, bearing in mind that those not yet vaccinated do not in any way benefit from others being locked in beyond what is necessary. But this is under the two conditions that A, the dimension of the threat can be objectively ascertained, and B, there is no compelling reason of public interest to apply the restrictions to all individuals in an equal manner, irrespective of the concrete threat. Next slide, please. So compelling reasons, according to paragraph 2, may include, in particular, practical difficulties in checking any certificates in the relevant circumstances. They may also include a possible demoralizing effect on other individuals, such as would be the case if vaccinated persons were not obliged to wear masks or keep social distancing in public spaces. Also, a high level of safety requirements, such as in old age homes or hospitals, may justify further restrictions. And it has been pointed out that lifting restrictions for individuals who have recovered from COVID might set false incentives and lead people to deliberately seeking infection. This is why paragraph 2 clarifies that, should this be the case, the state may wish to exclude recovered individuals from the scheme. Next slide, please. What has been said so far applies to the public sector, i.e. to the state, where parties from the private sector make the conclusion of a contract, such as the sale of goods or the provision of services, conditional on vaccination or any other proof of low epidemiological threat. This is a different story, as private parties may normally freely decide with whom they make a contract. And this is what paragraph 4 of Principle 16 deals with. However, there are limits to this freedom, and this is likewise stressed by paragraph 4. So paragraph 4 clarifies that this may not lead to a violation of non-discrimination law, nor to a situation where individuals who cannot show a certificate would possibly be deprived from goods or services of essential significance. Now, this is in a nutshell what Principle 16 is about, and I can now hand back to the chair and to the next principle.
Thank you very much indeed, Christiane, for that very clear explanation of the principle of proportionality and how it applies to the state and how it applies to private dealings. We now turn to Professor Pascal Pinochet, professor at the Fribourg and a vice president of ELI, and to become its president in due course. He is going to talk about the equitable equitable distribution of vaccines, something that is a matter that is close to so many people's hearts and their families' hearts. Pascal.
Thank you very much, John, for this nice introduction. And as already mentioned, vaccination, vaccination is a core factor in the fight against the COVID-19. This is why we thought that it might be appropriate to have an additional Principle 17 dealing, as you said, with equitable distribution of vaccines. Now, this principle brings up several issues, both on a micro and on a macro level. First, as to the micro level aspect on how to prioritize the vaccination of people in a given member state or in a state in general. The World Health Organization and the Council of Europe, for instance, have come up with several sets of large or long principles. Countries have also their own strategies. Now, these are sometimes very detailed, yet also different from one member state to the other. Now, according to the philosophy of our principles here, we have tried to grasp the main aspects to ensure a kind of common understanding. I would say on prioritization of vaccination, our principle is in line with the commonly shared aims, i.e., the administration of vaccines should comply with the principles of fairness and equality in design and in impact. Both, therefore, design and impact are fundamental here, as it is stated in the paragraph 1. As to the order of priority, which should comply with the gradual building up of vaccination capacities, which is, of course, still an ongoing process, and we hope that the speed is growing and growing, we propose, in fact, 3 criteria. First, vulnerability with regard to the acute effects of COVID-19 and its variants. This is targeting to the so-called risk groups, which might be subcategorized as in most countries, in fact. I've just heard that in France, for instance, people under 70 will soon get the right to be vaccinated. However, what is important is to take into account the vulnerability aspect as to the effects on people, since proportionality means also to aim at choosing the option which is the most efficient for the target aimed at. This means that categorization may change with some variants having stronger impact on other layers of the population, which means also that the targets or the prioritization may change over time if one should realize, and when I say one is the scientific community, that some variants need a different approach. Second aspect, second criteria, a necessarily higher risk of spreading and multiplying factor. This factor implies that vaccination prevents the spreading of the COVID-19, which is not yet fully established. But there are, so far as I know, good indications that this might be the case. In that situation, multiplier factors should be treated first, or at least at a higher priority. Of course, one can think of a person of healthcare workers going from room to room, but this might also be covered under the next point. This might also deal with, for example, school or university teachers. Of course, I'm speaking now for my own position. Third criteria, systematic contact with ill and vulnerable persons, as well as key individuals for the functioning of the public state. I don't think I need to say much about that criteria. This deals primarily with people working with risk groups under the first criteria and some key individuals, because of course, if the key individuals are all affected, the functioning of the public state itself is at threat, and that's also a problem. Obviously, some people will fall under several categories, which might justify a higher level of priority. As to the registration now, this is litera B. It should be designed in a non-discriminatory way, given that risk groups may be also disadvantaged in using registration schemes. Most countries have developed a system to identify people at risk through, for instance, family doctors, but it remains that the prioritization depends on having all information centralized. So on one hand, you need several ways, but then you need to centralize the information to avoid abuses and to be able to prioritize things in the right way. As to the administration of vaccination, this is point C, apart from the need for appropriately trained staff, one has to underline the zero waste approach also promoted by the EU. Indeed, everyone has heard about issues linked to vaccines having been wasted because remaining doses when containers had multiple doses could not be used, or because of the need to use vaccines once defrozen and you had not people. So here, this is a concern as well. Now we have heard about the issue linked to second shots. Some countries have had larger groups vaccinated with one shot and later with second shot, sometimes due to the type of vaccine, of course, sometimes as a strategy to reduce the risk of spreading. Now, one should stress that what is at stake is the principles of precaution and efficiency, and also the documentation, transparency, and reliable of scientific data to make those choices. It is certainly not the role of the ELI, to say what has to be done exactly, but it needs to be transparent. Now, next slide, please. It is also not the role of the ELI to fix the best strategy, but what is important is to ensure that transparency as to the strategy is also brought to the people. The principle of precaution and efficiency should be determined according to 2 points, we think, A and B here. One is that in particular, there should be an assessment of risk which is determined whether, or which would determine whether public health imposes a second shot, and also everything should be well documented. Of course, it may be that with some variants, the vaccination needs to start almost from the scratch again. And this is the reason why it is so important to be quick with vaccination, as we all know. Hence, Principle 17, paragraph 3 deals with an open approach, because it's difficult right now to say whether with new variants you need to comply with the same type of priorities, or maybe you have to change priorities, or maybe you have to vaccinate first people who are unvaccinated and then others. It is one thing to decide how to prioritize people for vaccination. It is another to ensure an equitable distribution of vaccines, in some cases already within a specific country. We had the case in some federalist country like Switzerland as well, but more importantly between EU member states and then of course worldwide. This is a macro level perspective addressed both in paragraph 4 and paragraph 5 on the next slide. Paragraph 4 addresses the issue in between EU member states. Between EU member states, the principle of solidarity should of course apply. This is a fundamental principle of the EU, and a mechanism of coordination should therefore be put in place. The EU vaccine sharing mechanism is part, of course, of this endeavor. In its communication of 17 March 21 on a common path to safe and sustained reopening, the EU Commission presents, of course, mainly the issue linked to reopening to allow tourism and the economy to go on, especially with the digital green certificate on which we will come back. But it comes also, it deals also with the testing, tracing of people within the EU. But in this communication, one can read also a section on building global resilience against COVID-19, which starts with the observation that, and I quote, no country or region in the world will be safe from COVID-19 unless it is contained at global level, and only at global approach can bring a solution to a global crisis. In this respect, the EU Commission has announced to engage in tackling COVID-19 worldwide, supporting international partners and countries around the world through the so-called Team Europe approach. It intends to foster vaccination worldwide by supporting the work of COVAX with more than, I think, 2.2 billion in finances. Now, here, I think the Principle 17 brings in that element as well, because as rightly stressed by the EU, EU and its member states are establishing a coordinated European approach first, that's subparagraph 4, but need also to target the broader approach in order to be able to reopen as swiftly as possible. The aim is to further support and go beyond existing bilateral initiatives by member states and to create and scale up an EU pot fed in an equitable manner by a share of doses from member states. So there's a kind of tricky but very difficult balancing between micro and macro approach to equitable distribution of vaccination. And that's at the heart of Principle 17. And with that, I can hand over again to the chair.
Well, thank you very much indeed, Pascal, for that very clear exposition again of the principles of equitable distribution and how they should work in practice. Now, before we go to our next speaker, may I remind people, because I see one person has already done so, that there is the opportunity to ask questions using the question and answer session. No, I hope that the presentations will have provoked a lot of questions, but now I hope that the two next contributors to this webinar will help stimulate us even further. And it's my pleasure now to introduce Dr. Ritva Halila, who has for what is a very long time, since 1999, been a member of the Committee on Bioethics of the Council of Europe, since she then joined its bureau, and in November of last year was elected chair of this committee. I can think of no one better qualified than to address the questions in relation to vaccination and to give her views on principles in general and ELI's principles in particular. May I welcome her and also say how wonderful it is that the technology has enabled us to see her as well. Thank you very much. Dr. Halila.
Thank you. Thank you for a very nice presentation. I don't need to present myself. I'm the chair of the DH Bio, but I am also a medical doctor, pediatrician, but I have been working a long time in ethics and administration, so that I haven't worked so much in practice in pediatrics. And I have been there in DH Bio or CDBI at that time since 1999, as we heard. The Committee of Bioethics was established already in 1985 as an ad hoc committee of experts in bioethics, and in 1992 it became the steering group of bioethics, and in 2012 it became the Committee on Bioethics after an organizational change in the Council of Europe. So that you get a short introduction about the DH Bio. But the COVID epidemics has challenged the healthcare overall in the world, also in my country, in Finland. It has not respected borders and has caused millions of deaths and a lot of suffering. There's no specific medication, as you know. Now there is some light ahead while several vaccines have been produced into the market. While the need for vaccines is huge everywhere, there is not enough vaccines for all, not at the moment. And that's why we have to prioritize. The DH Bio took also its share in public discussion on this pandemic. It first published a statement on human rights considerations relevant to the COVID-19 pandemic. In this statement, the DH Bio based its message to the Oviedo Convention and emphasizes Article 3 of the Oviedo Convention.
Well, while the technical team is trying to deal with Dr. Halila, I think what we'll do is to move to our second speaker. We're very privileged as well to have Professor Iñigo de Miguel Beriain, who's a research professor at the University of the Basque country.
Yeah.
He is enormously well qualified to speak to us this evening, having not only a background in economics and business management, but in law, and has spoken and taught widely across Europe. In his research, it's aimed at the philosophy of law, ethics in the economy, bioethics, and medical law. And this is particularly relevant to examining, and he's going to explain a bit of his work to us, but particularly important in examining the principle 16. So if we go to that, and Professor, if you're able to talk now, this would be marvelous. And we'll come back to Dr. Halila, we hope, in a few minutes.
Yeah, indeed. Thank you so much. I hope you hear me well. Well, first
indeed,
of all,
very well.
Yeah, thank you. So please, first of all, let me thank you for your kind invitation. I really hope that I will be able to, to be somehow useful for what you are trying to do. That I think that it's a really, impressive effort to simplify things. But I must say in advance that I really like your principles. So what I will say afterward about them will be just minor remarks, some things that come to my mind, but are just minor remarks. So in general, I am now working on leading an EU-funded project that is called PANELFIT, and it has to do especially with data protection issues. When we started with that, it was especially explaining about the GDPR and how it works more or less. Once that the pandemic started, of course, we were focusing also in data protection issues related to public health and so on. And especially, I I focused on the everything related to immunity passport because I worked for quite long in another EU-funded project that was called Eden, and it was aimed at improving our response to really huge crises. So I had a quite a training done in related to this. And when everything started, one of the things that really seemed so impressively strange to me is that everybody was so, totally against immunity passports in so many ways. 1 year afterward, the EU Commission is somehow offering us a type of immunity passport. We could call it in the way we want, but it's something like that. The digital green certificate, indeed, in my opinion, is something like a kind of a certificate that just shows that someone is not infectious, that cannot really spread the virus. That's what the digital green certificate assesses, that you are not dangerous for the rest of the people who are sharing a space with you. That's what we have. As you might know, the idea of the Commission is that this digital green certificate will serve to help us improve our situation and start opening the boundaries to travels and safe traveling. And I think that this is a good idea in general. I honestly think that the Commission is doing right with this. The point is that if it is really possible to ensure that you are safe and you can check if someone is infected or not. In fact, the digital green certificate is built on the idea that this is possible, and indeed it will cover 3 types of certificates: vaccination certificates, test certificates, and certificates for persons who have recovered from COVID-19. Of course, this is arguable from a scientific point of view, and we could discuss on that afterwards if you wish. But I will especially focus on the other type of issues that are much more related to what we do. And those are especially issues related to discrimination, equity, and privacy and data protection issues. Well, I think that none of these issues is really decisive against immunity passport. I will try to explain why. Discrimination issues more or less says that why should we impede some people to get access into an airplane, for example? Isn't it discriminatory? Well, my answer is quite simple. Yes, it is discriminatory, but it is not an unfair discrimination. And this is due to a very simple thing. In pandemics and in any kind of epidemics, what we are always trying to do is to separate people who can spread the virus from people who cannot. That's what we always do. So it's not discriminatory to try to follow this kind of logic. Indeed, it will be absurd to do the opposite. If this were Ebola, we will not having this discussion. Nobody will be really discussing if we would allow someone with Ebola, getting into an airplane with some of us in there with no kind of, certificates in there or anything like that. So I don't really think that it is. There is a different issue that has to do with equity. And this is much related to the access that we might have to any of these 3, ways to win your certificate. If this is not possible for everyone, then we will have an issue there. But this will have to do with equity and the possibility of the access to one of these type of media, the type of things that will give you the passport. And the last thing, it's much more related with privacy and data protection issues. Lots of people are thinking that this might be a kind of a Orwellian world that we are building, and the state will get a lot of data about ourselves and so on. Really, I don't think this is going to be the case. And the Commission is already saying that data will remain in the member state that is giving the certificate, and there will not be exchange of data and so on. My only issue about this is that when I've seen the project that they presented, well, I think that this could be done in a better way due to a very simple reason. When you present the digital green pass, it will show whether you are vaccinated or whether you obtained the test or whether you passed the disease in the last months to someone who is not a healthcare professional, And I think that this could be avoidable. they could have introduced this information in the QR, and that will be a kind of, confidential information. You will just introduce that into a kind of a lecture, and then there will be a green or a red light. And the one who is just controlling access will let you go in or not without knowing what's the concrete reason why you are not dangerous for the rest. So that's the only thing that I think that could be improved in terms of data protection related to the green passport. And just let me finish more or less what I have to do with two comments about the principles that I think that might be interesting for you. My main point is that I think that in general, in my view, there's something that always works bad with one part of that. You introduce this part by saying, like, exceptionally, a state may consider reapplying restrictions to individuals who are recovered from COVID-19 despite a low epidemiological threat, where there is evidence that lifting the restriction has led to a relevant number of persons deliberately seeking infection. This is a quite common argument. I mean, lots of people are saying something like this. It's just like, no, if you introduce that, that will be a kind of a privilege for some people. And then you will be somehow provoking that some people are getting infected voluntarily, and this will be terrible. That will be a kind of a nightmare. Well, in my view, this makes sense, or might make sense from the perspective of policy making and the idea of realistic policies, but not from the perspective of ethics. Because as I see, the situation is more or less, and I think that Christiane at least is totally on my side on this, and I hope so, that we have misunderstood this scenario. What really happened is that we had a scenario in which people enjoyed rights and freedoms, such as freedom of movement, which is, by the way, recognized in Article 5 of the European Convention on Human Rights, if I'm not wrong. So it is a very important, a fundamental right, and you cannot introduce restrictions to that right if it is not under a very nice basis. So when SARS appeared, we had no choice but to deprive everyone of that right, because we could not distinguish who was really dangerous, who was contagious, and who was not. And that was the justification for the lockdown and the common restriction of this right. But at a concrete moment, we were able to diagnose the virus quite well and distinguish between infected and uninfected people who could be dangerous for the rest of not. So consequently, it became possible to give some people back their rights. And it's very important to use the word give them back, because we are not really providing something new to people. We are not creating a privilege. We are just coming back to normal situation. That's what Christiane was saying, and I totally agree with her on that. So the main problem is that whoever is saying something like, no, but we shouldn't do anything like this because this could provoke, an extension and so on. And this could provoke that some people are really, seeking for contagion just to have that. I don't agree with that, because that will be like saying, no, we should not give your rights back, because otherwise some people could do wrong and voluntarily get infected. And since we don't want this to happen, you will be not given back your rights. And I think that this does not work so well from an ethical, from a legal point of view. I'm much more, I'm on the perspective of the individual human being. So I don't agree with that. And just a final and very, very brief comment on Principle 17. You got one very interesting thing in number 1A about the order of priority. And you say that one of the issues should be systematic contact with ill and vulnerable persons. I just wanted to let you know that this is a very nice principle, but it could work in two different ways. If vaccines provide with sterilizing immunity, then of course it will be good to start vaccinating people who have systematic contact with ill and vulnerable persons. Instead, if it happens the opposite, if you have a vaccine that works very well and impedes that someone is suffering from the disease, but it's not providing sterilizing immunity, then you have a danger if you give the vaccine first to those people, because you will be creating lots of asymptomatic carriers. And this could be very, very dangerous, in my opinion. So you should always keep in mind that sterilizing immunity is key on this kind of distribution of resources. And that's all I would like to say. That's all. I hope that I have not talked too much. Thank you.
No. Well, thank you very, very much indeed. Now I'm going to hope that Dr. Halila is able to rejoin us. She came back during the presentation. Ah, wonderful, Doctor. You're back with us.
I'm back with you. Thank you very much. I don't know when I dropped away from the line, but anyway, so I was talking about the first statement that DH-Bio made at the end of last year. It based its message to the Oviedo Convention and emphasized Article 3 of the Oviedo Convention. Probably you heard that already. But yes, also in the situations where vaccines are coming in the market and need for vaccines is overwhelming all around the world, it's important to bear in mind the basic principles of human rights, especially the principle of equity in access to healthcare. After the first statement on equality in rights to access to healthcare, the DH-Bio published another statement on ensuring equitable access to vaccination during the current and future pandemics. There, the DH-Bio emphasized again Article 3 of the Oviedo Convention. This means that states should, but in the second statement, the DH-Bio emphasized that procedures developed for vaccine distribution within the groups must be non-discriminatory in design and in impact. That's what you have been talking also in your statement. Every person who is eligible to receive a vaccine should be able to receive it regardless of socioeconomic status, geographical location, age, physical abilities, health, gender identity, sexual orientation, educational and literacy levels, language, nationality, ethnic background, religious or philosophical affiliation, political opinion, or other socially determined circumstances. The DH-Bio emphasized that if vaccination free of charge can't be achieved, measures should be taken to ensure that any possible fee for the vaccine or its administration does not represent a barrier for access to vaccination for any person or group. Vaccination, allocation, and distribution strategies should be designed so as to prevent acts of corruption, arbitrary exceptions, priority access on the basis of financial capacity, manipulation such as lobbying, political interference, or deliberate ambiguity. The DH-Bio emphasizes that access to vaccination services should be tailored to the needs of persons in vulnerable situations having difficulties in accessing health services. These include persons with disabilities, mental health problems, or learning disabilities, minority groups, homeless and poor people, persons with addictions, illiterate, and persons with institutions, low-income migrant workers and paperless, and persons with insecure legal status as refugees, asylum seekers, or undocumented migrants. In many countries, elderly have been prioritized and persons with diseases that can cause greater risk for severe type of disease. After these groups have got their vaccines, then the DH-Bio wanted to emphasize the persons in higher risk to get the disease or disseminate it to others should be prioritized, not only for their sake, but for greater efficiency to affect the pandemic, lower the number of deaths, and lower the pressure to healthcare capacity. The DH-Bio also emphasized, now I leave the video away so that if you hear my voice, so maybe that's better than nothing. So the DH-Bio has also emphasized transparency, information, and communication that are essential to contribute to building trust and the promotion of public dialogue. The public should be provided with clear, accurate, understandable, and reliable information about available vaccines and how to access them. This information should be given in all needed languages, including Braille and easy to read or pictorial leaflets, and materials should contain clear, accurate, and up-to-date information on the vaccines and on how to access vaccination services. This is only a part of information in the statements. The DH-Bio emphasizes also that the pandemic is not over before all can have access to vaccinations, and the herd immunity causes the cessation of the worldwide spreading of the virus. This requires solidarity of rich societies to those that otherwise can't afford vaccines. This has already been seen in some countries where vaccines have been donated, and the COVAX program that was already mentioned in this webinar. But thank you for your attention, and sorry for all these funny things there in the internet connection.
These things happen, so please don't worry.
Yeah, that was not our fault, not yours, not mine.
Well, thank you very much indeed for joining us and for your very interesting contribution, and to both you and to the presser. Now, we've got one question or two questions that have come up, and I wanted to pose the first one of these, but I would be grateful if others have got questions, they could pose them on the Q&A session so we can answer them. Now, the first question is by someone from Italy who has posed this issue that there are some courts ruling that doctors and nurses must be vaccinated or they can be dismissed or suspended without salary. And some courts have ruled that the children can't go back to school if they're not vaccinated or PCR tested on a daily basis. I would ask, first, Christiane, for your comment on the situation disclosed by that question and how this should be dealt with by the application of the principles.
Yeah, thank you so much to Enrica Zenini for having posed that very important question. Actually, mandatory vaccination and all the problems that come with potentially mandatory vaccination are not really the focus of Principle 16. However, I would say that the proportionality principle stressed by Principle 16 is also applicable to that really important question. So we may not be able to treat all situations in the very same manner. There may be situations from a fundamental rights point of view, at least, where, for example, doctors and nurses are in contact with highly vulnerable patients who cannot receive vaccination themselves. So, for example, some cancer departments of hospitals. And there, it may be absolutely proportionate to have mandatory vaccination. And we may also have other situations where it may, at least at the moment, not be in line with the proportionality principle, at least not when there are other alternatives such as daily testing. That leads us, of course, to the very important and extremely controversial question whether there can be something like mandatory vaccination for certain groups of professionals, whether there can be general mandatory vaccination for the population. I would say that at least the latter is at the moment not really an issue, because at the moment we still hope that a sufficient number of people will get vaccinated and voluntarily, and that it will be possible to reach herd immunity just with those who voluntarily seek vaccination. And I think that whole debate about potentially mandatory vaccination should be postponed to a moment which we will hopefully not reach, where we find out that not a sufficient number of people is prepared to get vaccinated. So, but I think it's a very, very important point, and thank you so much for raising it.
Dr. Halila, did you want to comment on that question as well?
Yeah, that's a very interesting question, and thank you for that. We have discussed that also with the influenza vaccination in my country, not in the DH Bio, but anyway. So there we have been there are some nurses and also very few, but some doctors that did not want to have influenza vaccine. But there's also so employers are also responsible for the health of their employees, and so it's a kind of protective measure, the vaccination, and so if somebody is not vaccinated, so that's a risk also for the employer if the employees get sick. But influenza, that is also a very important issue, that if somebody is not vaccinated and probably is asymptomatic carrier of the virus, so then it could spread the disease also to patients that might have some serious diseases. So there are very many things that are there at stake. In our country, we still say that vaccinations are not mandatory, so they are voluntary to everybody, also to healthcare personnel. But in the case of influenza vaccine, so some administrators of hospitals have said that if somebody does not get the vaccination, so it could be transferred to other duties. But so that's not a very simple answer, that either. So there are not like right solutions for this issue. And another issue is the vaccination of children. So actually, the vaccines that are now in the market have not been studied with children under 15 years. So I'm not sure if that can be done in any country. So probably there is an issue in Italy, but not in our country, nor in many other countries.
Arising out of a couple of other points that have been raised in the course of the questions, I'll come to you in a minute, Professor, because I think you can cover it in the answer to the question I'm about to ask. One of the questions that's been posed now is the worry in relation to public acceptance. You said in your presentation that, you know, where if we were dealing with Ebola, people wouldn't have a problem. But of course, with this pandemic, there are many who think that it's either not serious or there's no reason to do anything about it. But in dealing with the principles of the proportionality of measures of a low epidemiological threat, how do we ensure that people adhere to the rule of law in circumstances where you may be imposing restrictions on people who you're not vaccinating, who are young, who think they won't suffer, but nonetheless, it's thought that this is in the interests of society. How do you reconcile people to this acceptance of the rule of law?
Yeah, well, thank you for the question. I will ask them. I will ask them both. I will start with the last one. Well, this is quite easy to enforce the law when this is always related with the access to some places. What is really difficult is to keep people at their homes. It's very difficult to do so, because it's not so easy to trace who is really, you know, holding a pass or a certificate or anything like that. This is very difficult. But when it has to do with the access to an airplane, for example, this is pretty simple. You don't have the certificate, you will not get into the airplane. So it's very easy to do. And I don't think that this will raise really, you know, huge issues in any way. And regarding to the former question, I just wanted to raise a point. I usually am keen on giving people some possibilities and freedom. So my point is that I'm against mandatory vaccination because I'm pretty sure that there are some other ways to arrive into the same result, and they could be even better. And coming back to the example that you were giving, imagine, for example, that someone is a doctor dealing with very vulnerable people. Well, you could say, we must make him get vaccinated. This will never make the risk of spreading the virus disappear, because vaccines might not work well, and it might happen that he or she is spreading the virus. Instead, test, especially in a daily basis, in such a kind of service would work much better in order to make sure that he or she is not being dangerous for someone else. The main problem that we have is that PCRs are too expensive in the way that they are, and we should start with, for example, pooling and saliva PCRs and so on. But unfortunately, we have not been so good in doing this in this year. That's all. I close my mouth.
Thank you very much. Well, now, can I go with the question to Pascal by Miguel, who says Principle 17.5 seems a bit weak. Should it not suggest something like, as soon as states have given the first vaccination to the majority of their citizens, they should release their stocks to COVAX?
Thank you very much, John. Well, think of the first shot to everyone, then in order to get to the level of immunity you want, you probably need the second shot. Otherwise, you might be in a difficulty, at least how I understand things. And so you need to find the right level in vaccinating, so to say, domestic people, so to avoid too large spreading and, of course, all the consequences. But at the same time, if you wait too long before sending over to COVAX or other strategic funds remaining vaccine, then you might lose all the benefit of having your own population vaccinated. But I'm not sure that just with one shot you will get what you are aiming at. And so it's probably a matter of finding the right speed between inland, so to say, and outland help of vaccination.
Thank you very much indeed. And can I go now to another question, which I think raises quite an interesting issue in relation to the epidemiological threat. And that is this: do you see as a right choice of the kind of the brand of vaccine? If someone thinks it's dangerous, is it right to exclude that person refusing to be vaccinated for a specific brand, or place that person at the end of the list? Should you therefore have freedom of choice of the kind you want? Or if you won't take what's on offer, should you go to the back of the queue?
Well, I suppose I have to answer that difficult question. And
I think it's probably, it poses to all of you, I think.
Yeah. Maybe I'll begin. And so, of course, I'm not a medical doctor. So the question is also whether the threat is objective or whether it's a subjective belief of the threat. And in some way, I would say, as long as you can get vaccinated and that these vaccines have been authorized by official authorities, then it's also a matter of how do you trust into the system itself? Because if you have a proceedings, can you then base the reallocation of priorities just on the basis of subjective belief? At least I do not give the choice. I would not give the choice, because I think as long as the vaccines have been authorized by the competent authorities, then if you do not want to be vaccinated for one vaccine, I don't think you can just say, I want another one. Whether you can be punished for it, that's probably too much based on the freedom of choice, probably. It would not be proportionate, I would say.
Christiane, do you want to comment on that? I'm going to ask each of you this rather difficult ethical question.
I fully agree with what Pascal has said. I think we have to differentiate between objectively well-founded concerns, should it turn out at some day, which I don't think it will, that particular vaccines pose particular threats to a particular group of people, then I could imagine that there should be such a right. But as long as it's just rumors in the media where we don't really know, and then people, believe maybe that a certain vaccine is better than the other one, I would not allow people actually to choose on such a basis. because for several reasons, in fact, there would be fairness concerns, and it would dramatically disrupt the procedures of vaccination if we had these additional complications. We already see now that vaccination is maybe too slow, and then should accelerate, and that would cause additional delays.
Dr. Halila, can I ask you the same question?
Thank you very much. It is also a very good question and very difficult to answer. So the problem is that vaccines are very different, or there are differences between vaccines now, and so it is difficult to deliver them, and also and there is a shortage of vaccines, so that if somebody tells that this kind of vaccine is not suitable, I don't want to have this vaccine, so there is certainly another person that will wants to have it. And we don't have actually those vaccines that are in the market. They are pretty good all, and there are not big differences in contraindications or any kind of risks. But in that AstraZeneca vaccine, for example, that has been on hold, and so they are studying them more. So if there are risks to have those blood drops or whatever, then it might be questionable, or people can discuss about their fears and worries. So in individual cases, so that it is possible to have some kind of discussion, or if that person could have another vaccine, but they should not be sent to the end of the list. I wouldn't agree that. But it is a very good question.
Can I incorporate, before I ask Professor Beriain to answer that question, another series of questions that's arisen, essentially saying this is a new therapy. It may offend against people's freedom of conscience and religion. Should there be a right of conscientious objection to the type of vaccine, or to being vaccinated at all? Should there be some wider principle than merely objective belief? Yes, Professor Beriain, could you answer that, and then I'll ask anyone who wants to deal with that question.
Yeah, I can answer both of them. I mean, first of all, I don't think that we should get into the kind of conscious objection issue here, because vaccination is not mandatory. If it is not mandatory, conscious objection makes no sense. So it's about, and I think that in the future, it should not be mandatory. If there are some people who are not willing to get vaccinated, they could always perform the test. The only thing is that we should not really pay for the test. That should be the price for their conscience. So if they can pay for that, that will be that. But we are not obliged to pay for that, in my opinion. And regarding to the other thing, the other issue that we have there, in my opinion, we should just consider it in another way around. We are just offering vaccination. If someone does not want to get vaccinated, okay, we don't really need to know why. We just have to point out, to notice that he or she is not willing at this moment, and they can change their opinion after a while. Main problem is that they will probably not be in the same position in detail, but I think that the mentality is that we are offering vaccination. It's not that we really need to know why someone is refusing vaccination.
Christiane or Pascal, do you want to add anything to those very clear observations of Professor Beriain?
I absolutely agree.
Pascal?
I just wanted to add, even if it would be mandatory, which is not the case indeed, fundamental rights have always to be weighed against other fundamental rights. And then, of course, you cannot just say freedom of religion trumps all the other fundamental rights, including protection of weak people and protection of life. So I don't think we can just say yes or no. It's probably also a matter of weighing if it would be de facto mandatory, for instance, or mandatory.
Well,
can I also comment?
Yes, Dr. Halila, please.
Yeah, thank you. Yes, I agree totally with others, but then I would want to raise one issue is the parents. So there are people that are against all kinds of vaccinations, and as a pediatrician, I'm sometimes worried about children that are not vaccinated because the parents don't want them to be vaccinated, and that is a kind of big issue in my country. For example, if the children don't get MMS vaccine, so then we get epidemics in some parts. And I know that in Italy, for example, there have been the epidemics of mumps or measles, whatever. But that can be very serious and lead to death also. And that's why those vaccination programs have been developed. And so it's a kind of bigger discussion in the society what to do with if parents can decide or put a risk also for the children. Adults can do whatever they want and they can take their own risks, but if they are putting also more vulnerable people into risk. So that's a kind of a larger issue.
Well, thank you very, very much indeed. And there are one or two more points that have been made in the chat, as you will see. And obviously these will be preserved and taken into account, because what I think this webinar has shown are three things. First of all, how valuable it is to have people's comments, to raise questions, to test the strength and validity of the principles. And the only thing, and I hope that Christiane and Pascal won't mind me saying this, the more criticism that is leveled, the better, because it's better to get it right now. Secondly, I think it's very fair to say that these principles on their first outing have been very well received. And that is important because this has taken some time to develop. But thirdly, and I think the most important aspect of it is I think it's important to show that in going forward on these two very difficult areas of the equitable distribution of vaccines and the way in which you lift restrictions, you must do so on a principled basis. You must do so in accordance with the rule of law and principles of democracy. And I very much hope that these principles will be taken up by those who have to explain these decisions that they are making to the public. Because if you can show your decision is one that's based on fairness and on principle, you have a much greater chance of people voluntarily and happily accepting it. And also showing that by living by these rules of a fundamental and democratic society, governed by the rule of law, we strengthen the societies in which we live and realize that each doing his bit for the public good, may be inconvenient, actually makes us all better. So may I thank everyone for their participation, most of all those who've come along to listen, but also in particular Professor Beriain and Dr. Halila, and of course Pascal and Christiane for a wonderful evening for which I think we are all most grateful. It's a great pity you can't hear the applause on a webinar. Thank you very much indeed.